So today we'll be seeing acute respiratory distress syndrome part 1, which includes the definition, pathophysiology and diagnosis. And in part 2, we'll be dealing with the management of ARDS. So what is ARDS? It is a rapidly progressive form of respiratory failure due to excessive inflammation. It is a multifaceted syndrome characterized by dysregulated systemic inflammation, increased endothelial and epithelial permeability, diffuse alveolar damage, leading to alveolar edema, fibrosis, necrosis, and proteinosis. Coming on to the phases of ARDS, it has three phases, overlapping three phases, that is exudative, proliferative, and fibrotic phase. Not all patients necessarily have to go through all the phases. And the risk factors for ARDS are alcohol abuse, obesity, patients with higher Apache score, increased transfusion history, and septic shock. So, what is the etiology of ARDS? So, ARDS etiology can be divided into pulmonary cause and extrapulmonary cause. Pulmonary cause are the ones which causes direct injury. The infectious causes are bacterial pneumonia, viral pneumonia, fungal pneumonia, and the non-infectious direct causes are malignancy, immune like vasculitis or autoimmunity, hypersensitivity, eosinophilic pneumonia, aspiration of gastric contents, inhalational injury, pulmonary contusion, drowning, and idiopathic. Coming on to extrapulmonary, which causes indirect lung injury, infectious causes include extrapulmonary sepsis like UTI, abdominal sepsis, skin and soft tissue sepsis, and other non-infectious indirect causes are non-cardiogenic shock, multiple transfusions like TRALI, pancreatitis, major trauma, burns, and drug-induced. Coming on to pathophysiology. So here on the left-hand side, you can see the normal alveoli. Here, this is the ARDS alveoli, where acute lung injury and acute respiratory distress syndrome, they result from a cascade of inflammatory events that disrupt the normal alveolar structure and function. Whenever there is an insult, like an infection or a trauma, pro-inflammatory cytokines such as interleukin-1, interleukin-6, and tumor necrosis factor alpha are released by alveolar macrophages, leading to neutrophil recruitment to the alveolar space. And these neutrophils in turn release proteases, reactive oxygen species, and leukotrienes, causing damage to the alveolar capillary barrier. So there will be increased capillary permeability, allowing the protein-rich fluid to enter the alveolar space, resulting in pulmonary edema. At the same time, type 1 alveolar cells also undergo necrosis, while type 2 cells are damaged, impairing the surfactant production and exacerbating the alveolar collapse. So the cellular debris and fibrin deposition form the hyaline membrane, which is the characteristic of ARDS, further impairing the gas exchange. The fibroblasts are activated by like transforming growth factor beta or PDGF, leading to collagen deposition and potential fibrosis. These processes overall disrupt gas exchange, causing severe hypoxemia and hypercapnia, which is the hallmark feature of ARDS. Coming on to phases of ARDS. The first phase is the exudative phase, which happens within 4 to 7 days after initial insult, where the histopathological features are inflammatory cells like macrophages and neutrophils migrate across the vascular and alveolar surfaces, disrupting the endothelial and epithelial barrier tight junctions. So, increase in the lung endothelial and alveolar epithelial permeability, allowing not only the inflammatory cells, but fluid, protein, and red blood cells to enter the air space. There will be damage to type 1 and type 2 alveolar pneumocytes. Whenever there is damage to type 2, there is loss of surfactant and there is deposition of cellular debris along the alveolar airspace. So the alveolar airspace begins to fill with this protein-rich fluid and cell-rich fluid, leading to hyaline membrane formation. And the lung epithelial glycocalycial layer starts shedding, and there will be vascular microthrombi formation. In this typical phase, patient can have dyspnea, tachypnea, hypoxia. Coming on to chest x-ray, there could be bilateral opacities, which could be indicative of alveolar edema. Coming on to the next phase, that is the proliferative phase, which happens between 7 to 14 days after the initial insult. It is a body's way of recalibrating itself to repair. The anti-inflammatory cytokines facilitate the neutrophil apoptosis and clearance, and macrophages clear the cellular debris via phagocytosis. The type 2 pneumocytes begins to proliferate and differentiate into type 1 pneumocytes. And the integrity of the epithelium is trying to get re-established in this phase. and the fluid begins to be cleared via active transport and diffusion. Here, clinically, the patient can have worsening clinical features, refractory hypoxia, there could be right heart failure, hypercarbia, and there could be extension into the next phase, that is the fibrotic phase. So, fibrotic phase happens between 14 to 21 days after the initial insult. And here, the role of fibroblast is unclear. The fibroblasts are active in secreting the epithelial growth factor as early as in the exudative phase, and the growth factors aid in the recovery during the proliferative stage. If the proliferative stage is prolonged or impaired, the growth factors can be present in excess, leading to the deposition of fibrotic tissue, ultimately resulting in lung fibrosis. So here, the patient can have profound distress, pulmonary hypertension, right heart failure, hypercarbia, and death. So this dysregulated systemic inflammation in ARDS can manifest as both pulmonary and systemic complications due to the persistent activation of the inflammatory pathways. So this persistent activation can lead to alveolar capillary membrane injury, leading to increased vascular permeability and intraalveolar coagulation. Okay, so pulmonary effects include continuous ACM damage with elevated BAL neutrophils and albumin levels, and unrestrained coagulation and fibroproliferation, resulting in maladaptive lung repair with impaired gas exchange and worsened lung mechanics and ventilator dependency. Okay, but at the same time, because of the protracted inflammatory response, there are systemic manifestations which are happening. Okay, so there could be SIRS, there could be positive fluid balance, there could be multi-organ dysfunction, and there is increased risk of nosocomial infections. This is compounded by the growth of the bacterial pathogens, impaired opsonization, and defective neutrophil function. So the long-term consequences include cardiovascular and neurological morbidity, such as delirium, neuromuscular weakness, and post-traumatic stress. So coming on to the definition of ARDS. So let us see how the ARDS definition evolved. In 1967, Ashbag and colleagues defined ARDS as a syndrome characterized by acute onset of tachypnea, hypoxemia, loss of compliance after a variety of stimuli. In 1988, Murray and colleagues defined ARDS using their Murray lung injury score, which included chest X-ray, PF ratio, PEEP, and compliance, which we will see later when we are discussing about lung injury score. So the final score, called the Murray lung injury score, is calculated as the sum of the single components score divided by the number of the accounted variables. So it defines ARDS as three categories. Either there is absence of lung injury, or there is mild to moderate injury, or severe lung injury based on the score. Coming on to the next definition, in 1994, AECC defined ARDS as respiratory failure, which is acute in onset, which presents with bilateral infiltrates in the chest X-ray, with pulmonary capillary wedge pressure less than or equal to 18 millimeter mercury, or there is no clinical evidence of high left atrial pressure to rule out a cardiogenic cause for the lung edema, and they defined hypoxia independently of the PEEP level. So the severity of the hypoxia has been further classified into ALI when the PF ratio is less than or equal to 300, or ARDS when the PF ratio is less than or equal to 200. Here, the ARDS was characterized by the exclusion of cardiogenic cause of edema, but it did not include the respiratory system compliance calculation at the diagnosis, and they did not mention the PEEP level set. There was also a 2005 AECC Toronto Delphi method guideline, which defined ARDS with a clear definition of the acuity of the respiratory failure as less than 72 hours, with standardization of hypoxemia, that is PF ratio less than or equal to 200, setting a threshold of PEEP level at more than or equal to 10 centimeters of water. And they also included the static respiratory system compliance calculated with tidal volume of 8 ml per kg of ideal body weight in a sedated patient with a PEEP level of more than or equal to 10 centimeters of water. And with the presence of ARDS predisposing factor and radiological abnormalities, introduce the concept of airspace disease involving more than or equal to 2 quadrants on the frontal chest X-ray. And the role of echocardiography was mentioned to exclude a possible cardiogenic origin of the lung edema. Then came the Berlin definition in 2012, where acute respiratory distress syndrome is being defined as with four criteria. Number one, timing, that is within 1 week of a known clinical insult or a new worsening respiratory symptom. Chest imaging, that is bilateral opacities not fully explained by effusions, lobar or lung collapse or nodules. An origin of edema, where respiratory failure is not fully explained by cardiac failure or fluid overload, and need for an objective assessment like an echocardiography to exclude the hydrostatic edema if no risk factor present. And oxygenation criteria, where the oxygenation criteria can be divided into mild, moderate, and severe. When the PF ratio is between 200 to 300 with a PEEP of more than or equal to 5 centimeters of water, it is considered as mild hypoxia. And if PF ratio is between 100 to 200 with a PEEP of more than or equal to 5 centimeters of water is considered as moderate hypoxia. And severe with a PF ratio of less than or equal to 100 with a PEEP of more than or equal to 5 centimeters of water is considered as severe hypoxia. So this table gives us an insight about all the various definitions after Berlin. Like there are also modifications with Kigali and Mate. Kigali modification where they used SpO2 by FaO2 ratio for oxygenation, and Mate modification where they included the timing as 1 to 2 weeks, and most of the other criteria were equivalent to Berlin's definition. What are the limitations of Berlin's definition? In Berlin definition, we do use bilateral and diffuse pulmonary edema features, where a lack of a marker for non-cardiogenic origin of pulmonary edema is there, and the lack of a marker of pulmonary vascular permeability is also there. Coming on to oxygenation, a single measurement of PF ratio at ARDS onset or diagnosis as poor performance for definition or predicting severity. And there is also lack of standardization of the respiratory support settings for measuring PF ratio. It is very difficult to distinguish ARDS from acute hypoxic respiratory failure since clinical features and etiologies causes are similar. Coming on to lung mechanics, it is missing the dead space measurement and definition and progression, and hard to conceive a mechanically ventilated ARDS patient receiving PEEP less than or equal to 5 centimeters of water. Coming on to systemic inflammation. Definition and categorization do not account for non-pulmonary organ failure, which is present in most of the patients and a major determinant of outcome. Too much emphasis is given on the alveolar side and little consideration for the pulmonary vascular and endothelial cells, presence of pulmonary hypertension or right ventricular function. Categorization and subphenotyping. Missing stratification and subphenotypes based on the dead space, endothelial injury, biomarker levels, and modifiable or treatable traits. Coming on to mechanical ventilatory setting, it should be personalized based on etiology, lung physiology, imaging and morphology, and clinical and biological classes or subclasses. So this is the ARDS new global definition, which was redefined in 2023, where the time to disease onset, pulmonary edema remains the same, but the radiological features have changes. It is not only the X-ray, we can include CT or a lung ultrasound by a trained professional. And hypoxemia can be defined by SpO2 by FaO2 ratio also, where if it is less than or equal to 315 with SpO2 of more less than or equal to 97 is defined as hypoxemia. If suppose you're going ahead with PF ratio, then mild hypoxemia can also be defined when the patient is on high flow nasal oxygen with receiving more than 30 liters per minute. So these are also major changes. So what are the difference between the Berlin definition and the new criteria? Why this was the issue was addressed? So coming on to the timing criteria, where it was within 1 week of known insult or a new or worsening respiratory symptom, where the onset may be more indolent for some of the insults such as COVID-19. So when you include the patients with high flow nasal cannula, it will capture patients with more indolent courses, and therefore the timing criteria has not been changed. Coming on to bilateral opacities on chest X-ray or CT, which is not fully explained by effusions, lobar lung collapse or nodules, where sometimes chest X-ray and CT may not be available in some of the clinical settings, where we can also include the ultrasound to identify the loss of lung aeration as long as the operator is well trained. Okay, then comes the PF ratio. So pulse oximetric measurement of SpO2, FaO2 is widely used and validated as a surrogate of PF ratio. So it can be used to diagnose the hypoxemia. Okay, and requirement of invasive or non-invasive mechanical ventilation with a PEEP of more than or equal to 5 centimeters of water is required for all categories of oxygenation in Berlin definition, where high flow nasal cannula has been increasingly used in patients with severe hypoxemia who otherwise meet ARDS criteria. So, new category of non-intubated ARDS patients on high flow nasal cannula at more than or equal to 30 liters per minute who otherwise meet the ARDS criteria, and the modified definition of ARDS for resource limited settings does not require PF ratio, PEEP, or high flow nasal oxygen. Coming on to phenotyping of ARDS. So, there is always a substantial heterogeneity among patients fulfilling ARDS criteria. So, the subcategorization further into more homogeneous group is referred as phenotyping for more targeted intervention. So, the phenotyping methods for ARDS could be physiological, clinical, or biological. Physiological, where it includes PF ratio, death spreads, ventilation, driving pressure. Clinical, it could be direct or indirect causes of ARDS, organ dysfunction with ARDS like AKI, or it could be focal or a diffuse disease. Coming on to biological, it could be genomic, transcriptomic, proteomic, metabolomic, hyperinflammatory, or hypoinflammatory. So, why this phenotyping has been done? It is basically to increase the understanding of the ARDS pathophysiology and to improve outcome. And preferential inclusion of a subphenotype with a higher likelihood of developing the primary outcome results in increased statistical power, as in studies for prognostic enrichment. And selective inclusion of patients with an endotype who are randomly assigned to receive an intervention that targets that endotype will probably benefit more than an unselected population in studies, as in for predictive enrichment. And tailored treatment protocols can be studied for specific phenotypes in studies. That is why we do phenotyping. Here in the picture, you can see the ARDS patients have been divided into hypoinflammatory and hyperinflammatory type based on the inflammatory markers, where you can see the hypoinflammatory type had a less mortality and increased ventilator free days, whereas hyperinflammatory type had increased mortality and less ventilator free days. So basically, this phenotyping in clinical trials is basically to select a set of patients to see how the particular treatment is working in a particular group of patients, and also sometimes for prognostic enrichment and for predictive enrichment. Coming on to clinical signs and symptoms of ARDS. So it depends on the underlying cause for the ARDS. If suppose it is sepsis, patient can have all the infective symptoms like temperature, tachycardia, tachypnea, altered mental status, along with laboratory markers like elevated total count or decreased total count or elevated C-reactive protein. If the patient is having shock, then patient can have organ hypoperfusion, low MAP, oliguria, altered mental status, and elevated lactate levels. If the patient is having pneumonia, patient can have protective cough, fever, and pleuritic chest pain. If the patient has an history of trauma, then there could be associated bruising over the chest wall, associated injuries, the history of motor vehicle crash or fall from a height. If the patient had an history of inhalation injury, then we can look for facial burns, singed eyebrows, carbonaceous sputum, history of working near the organic solvents or toxic chemicals. If the patient had an history of fever, rhinorrhea, cough, with history of prematurity or congenital heart disease, then RSV can be suspected. If there is an history of drug abuse, especially inhalational, then drug toxicity can be suspected. If there is history of institutionalization and patients with developmental disabilities or decreased GCS, then aspiration can be suspected. If the patient had an history of needing water rescue, hypothermia, then drowning could be an etiology. Then, if there is symptoms of acute lung injury and blood transfusion within the previous 6 hours, then it could be a trial. If the patient had had fever, cough, myalgia, fatigue, shortness of breath, diarrhea related to COVID symptoms, it could be one of the SARS viruses. So, the diagnosis could be divided into the common investigations, the biomarkers, and imaging. Coming on to laboratory investigations, what we routinely do for any sepsis patient, like ABG, blood cultures, urine antigens, and if suppose that was not suggestive of anything, then we can go ahead and do BAL, gram stain culture, then comes imaging, then specific microbiological investigations, and if it is a non-septic cause, then any autoimmune etiology to be ruled out, and if that was also not significant, then biopsy can be tried. So this is a flow chart which has been taken from some of the review articles where it gives us how to assess the ARDS stepwise. First, you rule out cardiogenic pulmonary edema and then look for direct or indirect causes of lung injury. So always it is sepsis which we have to rule out initially. So rule out sepsis with blood culture, sputum culture, urine antigen examination, and multiplex viral PCR. If that comes inconclusive, then you can go ahead with thoracic CT scan, non-invasive diagnosis with pan-respiratory PCR testing, fungal biomarkers, viral biomarkers, and atypical pneumonia biomarkers. Along with that, autoimmune biomarkers and BAL can be tried. If there is no response, no improvement in the next 48 to 72 hours, all of these additional investigations can be tried. So this again shows us the approach to the ARDS. First, you take an history and look for any other risk factor. If that has been ruled out and initial sepsis has been ruled out, still the results are inconclusive and patient is not improving, then you can go ahead and do the thoracic imaging and BAL. If that is also inconclusive, then look for the pan respiratory PCR to rule out fungal, viral, and atypical pathogens or an autoimmune etiology. So this table tells us what are all the microbiological investigations that has to be sent. Like when the patient is not improving, the routine, apart from routine gram stain in culture, we can look for atypical pathogens, HIV serology, and other viral markers and fungal markers. And ANA profile can also be sent. And then comes in sputum. If suppose BAL was not available, then you can look for direct gram stain PCR or pan respiratory PCR. And BAL, if it can be performed, it is well and good. Then you can look for all possible pan respiratory PCR, viral fungal etiologies, and cytology can also be looked into. Coming on to chest X-ray, chest radiographic findings are non-specific because there will be mostly diffuse bilateral coalescent opacities which can be seen in any form of pulmonary edema. 12 to 24 hours after the initial lung insult, as a result of proteinaceous interstitial edema, these infiltrates appear. Within 1 week, alveolar pulmonary edema, island membrane formation could be there because of type 1 pneumocyte damage. And reticular pattern secondary to type 2 pneumocyte proliferation and fibrosis can also be seen. So, morphological features, there could be alveolar consolidation, ground glass opacities, interstitial edema with reticular patterns, or normally appearing lung parenchyma. In the dependent regions, there could be alveolar flooding by edema, inflammatory interstitial edema, and congestion of pulmonary capillaries. How are we differentiating between ARDS versus cardiogenic pulmonary edema? ARDS patient can have normal heart size, absent pleural effusions, absent curly B lines, and the presence of air bronchograms, and all regions of the lung rather than classic perialar pattern involvement could be seen. So this is a chest X-ray showing the complete resolution of ARDS in a patient from A to C. You can see from 3 days after admission to 5 days after admission. So there is a radiographic score called radiographic assessment of lung edema score based on the X-ray, based on the amount of consolidation. I mean the percentage of the consolidation involved in the lung zones and the density of the consolidation in particular quadrants of the lung. The RAIL score can be calculated, and higher the score, higher is the disease severity. Coming on to CT. In CT, in the early phases, there could be pulmonary opacification, which is defined as an anterior-posterior density gradient within the lung with dense consolidation in the most dependent regions, merging into the background of widespread ground glass attenuation, and then normal or hyper-expanded lung in the non-dependent region. If there are bilateral symmetrical changes, then it could be extrapulmonary ARDS. In pulmonary ARDS, it could be asymmetrical. And the ground glass opacification is nothing but the reduction in the air content of the affected lung, edema, and protein within the interstitial and the alveolar spaces. There can also be bronchial dilation within areas of ground glass opacification and pulmonary cyst, which may happen in the later stages. So the inhomogeneity of the appearances in a pulmonary ARDS is because of increased weight of the overlying lung, causing compressive atelectasis posteriorly, which produces dense opacification. With the positional change from supine to prone, this density gradient can quickly redistribute accordingly. In the non-dependent portions, the lung may be of normal attenuation or it may be lower if mechanically ventilated. So in acute stages, there could be lung opacifications, consolidations, and interspersed normal or hyper-expanded lung in the non-dependent anterior regions. There could be bronchial dilation or pulmonary stress, which is less common. Whereas in latent fibrotic stage, there could be coarse reticular pattern, fibrosis in the anterior more than the posterior regions, residual scattered GGO, traction bronchiectasis, pulmonary bullae, and cysts. So this is a CT showing either a focal or a diffuse or a patchy consolidation in an ARDS. So there is also a score called Ichikado scoring in CT, where the CT findings in a patient with ARDS can be graded between a scale of 1 to 6, where normal attenuation is taken as 1 point, if there is GGO 2 point, if there is airspace consolidation 3 point. So higher the score, more advanced is the disease. Coming on to lung ultrasound, the lung ultrasound here can be used for examination, diagnosis, and see the response to the management of the ARDS, where we use an ultrasound score called lung ultrasound score, where for examination of the lung ultrasound, you are dividing the lung into anterior, lateral, and posterior field using two lines, that is the anterior axillary line and the posterior axillary line. And each field, okay, is divided into superior and inferior using two axial lines, one drawn at the level of diaphragm and one drawn 1 centimeter above the nipples. So a total of 12 regions will be assessed using a two-dimensional view with a probe placed perpendicular to the chest wall. Basically, the lung ultrasound is evaluated for the following signs. One is the pleural line, which is an horizontal hyperechoic line between the ribs. Then comes the A line, which is nothing but the horizontal reverberation artifacts repeated at a constant distance equal to the distance between the pleural line and the probe surface. And the B lines, which is the vertical hyperechoic reverberation artifacts deriving from the pleural line, and consolidation, which is nothing but the presence of tissue-like pattern. So this is a picture showing us the lung ultrasound finding with the corresponding CT finding. So when it comes to lung ultrasound, there are two scores we are looking at. One is the lung ultrasound score, which you just saw, and the lung aeration score. So lung ultrasound score is the one where there is quantification of the lung aeration status at a point in time. Whereas lung aeration score is nothing but changes in the aeration due to the interventions. It is basically a response to the treatment. So based on the severity of the findings in each zone, LUS score is calculated. Whereas lung aeration score emphasizes the changes in findings, whether there is gain or loss with the treatment. The purpose of lung ultrasound score is mainly to assess and monitor. Whereas for lung aeration score, whether the intervention was effective or not, that is being evaluated. You can see that from normal to B1, B1 to normal. So this is called loss of aeration or re-aeration. So this is called lung aeration score. So when it comes to lung ultrasound, so you can see that when there are only A lines, the score is 0. When there are B lines less than 50% of the pleura, then the score is 1. When the B lines are more than 50% of the pleura, then the score is 2. And when there is consolidation, it is considered as score 3. So the lung ultrasound findings specific for ARDS are abnormal pleura and subpleural consolidations. So how are we going to differentiate the ARDS from the cardiogenic pulmonary edema? In ultrasonography, there could be bilateral B pattern, non-homogeneous distribution, pleural line abnormalities, thickening or irregularity, absent or reduced lung siding. Whereas in cardiogenic pulmonary edema, there could be bilateral B pattern, homogeneous distribution, pleural effusion more than or equal to 20 mm, and there could be left-sided predominance. In cardiac ultrasonography, in ARDS, there could be preserved or unchanged left ventricular function from the previous examination, normal or small inferior vena cava, measuring diameters less than 23 millimeter. Whereas in cardiogenic pulmonary edema, mild, moderate, or severe LV dysfunction, there could be distended IVC with diastolic dysfunction also. So coming on to transesophageal echo to rule out the causes of hypoxemia, where we can use apical, mid, and basal views to see the lung, visualize the lung, and also the heart. So coming on to severity scores. So we have various severity scores. One we already saw, that is the radiographic score, and we already know the PF ratio. And other scores are lung injury score, oxygenation index, ventilatory ratio, AB score, and compliance. Coming on to lung injury score. This is the Murray lung injury score, which I was explaining you about during the definition. So it has 4 components, where each component is being graded between 0 to 4. So it includes chest radiographic finding, hypoxemia score, PEEP score, and respiratory system complaints. So you can see each is being given into 0 to 4 grading. Okay. If the score is 0, then there is no lung injury. If there is mild to moderate lung injury, then the score would be between 0.1 to 2.5. If there is severe lung injury, then the score is more than 2.5. Okay, so the total lung injury score is obtained by dividing the aggregate sum by the number of components used. If one component is unavailable, then the lung injury score would be the sum of the other three components divided by 3. Then comes the app scoring system, which is nothing but age, plateau, and PF ratio score, where based on the age, PF ratio, and plateau pressure, scorings are given between 1 to 3. So higher the score, poorer is the outcome. So what are the differential diagnoses of ARDS? There could be cardiogenic cause, or it could be a first presentation of ILD, and infections like bacterial, viral, fungal pneumonia, and any other interstitial lung diseases and vasculitis like good pastures or GPA or EGPA, autoimmune diseases, medication related like amiodarone, chemotherapy, TK inhibitors, and radiotherapy associated, and other malignancies like lymphangitis carcinomatosa and intrapulmonary lymphoma. So this completes our ARDS part 1 lecture.